to the PFC podcast. The views and opinions you are about to hear are the speakers and do not necessarily reflect those of anyone else. Now on to the podcast.
Welcome back to the PFC podcast. This is Dennis, and today I have a very special guest. Today I'm with the director of the J.C. Burn Center at University of North Carolina, Dr. Bruce Cairns.
Good afternoon, Dennis. Thanks for having me on.
Dr. Cairns, what I would really like your expertise on is a few questions I have from the PFC Burn CPG, and I haven't really been able to get a great answer on it through my own reading. So let's jump into my first question, which is burn formulas. So we have the Parkland formula, you have the Brooks formula, we have the rule of tens, we have modified Parklands, we have modified Brooks. What is the fascination with these burn formulas? In my just opinion, we should be starting them on some fluid, 500 mLs an hour, and then start titrating to a goal, a urine output goal or a blood pressure goal, signs of perfusion. What do you think about that?
Well, it's a great question, and it's one of the foundational principles for burns that we have these formulas. What's interesting about burn shock resuscitation, say compared to hypovolemic shock or septic shock, is the pharmacologic nature of the fluid administration that has to occur over time. What I mean is, as you notice in the guidelines, which I completely agree with, and I know the burn experts who put this together. It's really outstanding work, and it's very useful in the field. But to get specifically to your question about sort of how do we think about this, it's we don't give fluid boluses. So why is that? And you'll notice also in the guideline, you're not supposed to catch up, even if there's been a delayed resuscitation. And why is that? Why is it that you have to give a certain amount of a certain kind of fluid over a certain amount of time to avoid either under-resuscitation or over-resuscitation? And so the fundamental question is, what's going on with someone that requires this kind of formula, whether it's the 2 cc per kilo or the 4 cc per kilo or the rule of tens? And we don't really, at the end of the day, understand the fundamental principle that requires burn shock resuscitation. But I do think we've gotten closer and closer to being able to not only over-resuscitate or under-resuscitate in the hospital, which was a problem until recently, but also in the field. And in order to get that right, though, there are some extenuating circumstances that would lead you to do one thing or the other. Okay.
Which do you think is easier, since you talked about over-resuscitation, under-resuscitation? What is the most common side that this gets errored on?
Well, you would have to help me understand what's available in the field and how long somebody would be needed to be resuscitated and with what kind of fluids. But the issue is complex because it's related to how you assess the burn itself. First-degree burns don't count in resuscitation. Second-degree burns can be superficial or deep. And third-degree burns can cause a strangulation of the tissue so that you have to do escharotomies. Failure to do escharotomies increases the need for volume resuscitation. And so it's a long-term shock over that's relatively low, but it causes enormous trouble for local tissue as well as resuscitation requirements. And the same thing is true for inhalation injury. It also generates a fluid requirement. So in order to answer that question, one has to talk a little bit about how we assess a burn and how deep it is and how big it is.
Okay. So I guess in my small world, I'm just visually examining it. I use the rule of nines.
Yes.
Or you can also use the rule of palms, where you just use the patient's palm size. But the problem, I think, in the pre-hospital stay is that usually the patient is covered in, not only they're burned, they're covered in dirt, they're covered in who knows what. So that can affect the visual estimation of the burn size.
That's right. And when I was looking at the guidelines, again, sort of in the idea of helping people resuscitate, there is the rule of tens. Is that right?
That's a burn, the fluid formula.
The fluid formula.
Yeah.
And the way I think about this is just a little bit of a modification. So let's say we were to use the 4 cc per kilo. I think that's the Parkland formula. Yes. And let's say you had an 80 kilo person, and they had a 50% burn. And I'll get back to what it means to have a 50% burn in a second. But if you do all those numbers, you end up with 16,000.
Right.
And so if you divide that by half,
right,
then that's 8,000 in the first 8 hours, and then 8,000 in the second.
16 hours.
The later 16 hours. But that's calculates out to 1,000 cc's an hour for the first 8 hours, and then 500 cc's an hour for the next 16 hours. But it's then very simple, I think, to think about if you have a person whose body is 50% burned, run them at 1,000 cc's an hour for 8 hours, and then 500 cc's an hour for 16 hours after that. And the reason I think that's easy to remember is because you have, first of all, it's based on a formula,
right,
but it gives you a very easy foundation. You don't really have to know how much somebody weighs. You don't even have to know how much their second or third degree burn. You just need to say, okay, if half their body is burned, based on, say, the rule of nines,
right,
give them a liter an hour for 8 hours.
Okay.
And then 500 cc's an hour for the next 16 hours. And then you can calculate exactly how many bags of LR you need.
Right.
Now, obviously, then, if you're 25% burn, you cut that in half.
Okay.
So you get 500 cc's an hour for the first 8 hours, and then 250 cc's for the next 16 hours. And the reason I talk about it this way is that the rule of nines is useful, and even more sensitive and specific is the Lund-Browder chart.
Okay.
Have you had a chance to look at the Lund-Browder chart?
I have.
Is it easy to remember?
Yes.
As opposed to the rule of nines?
Yes.
So it's easier, though, even more so. I see the rule of tens as a 500 cc's, say, for 50% burn, I guess, depending on the size of the individual, and you add some hundreds. But what I would say is that you can't really tell what the percent burn is. That's what you're just telling me.
Right.
You're telling me that the patient is that you could be in a hot zone where there's all kinds of stuff going on. There's no light. There's dirt. You can't really tell, but you know they're burned.
Right.
They may also be a trauma patient.
That's right.
So the real issue is, can you tell the difference between a first degree and a superficial second degree, and a more deeper second degree, and then clearly a third degree? Because if you have a third degree burn with some contracture, then you're going to start talking about doing escharotomies, which we'll talk about in a second. But I think the real issue is to decide if you can give a liter an hour of the 50% burn, you give 500 cc's an hour for a 25% burn, then that means you give 1,500 cc's an hour for a 75% burn. Now, I realize that in the guidelines there's concern about over and under resuscitation, and you asked me that question.
Yes.
I think most people who are out in the field are probably a little bit dehydrated.
Right.
The key is not to treat the patient as if they have blunt or penetrating trauma, and give them 2 or 3 liters of crystalloid up front, and then give them the formula.
Right.
If they truly only have a burn, the key is that you can't catch up, and that you have to give it over 36 hours. That's that sort of pharmacologic idea I was explaining earlier we don't have a good handle on. The other is that people will have a tendency, and the gold standard without a doubt is urine output.
Mm-hmm.
So if you can get a Foley in, great, but if you can measure the urine output, that would somehow figure out what the urine output is. Sometimes you can use blood pressure and heart rate, but at the very beginning of a big burn sometimes, even if somebody's very hypovolemic, their heart rate will be low, which is interesting. And their urine output may look okay, and then it sort of draws off as their heart rate goes up. So what I would say is that the reason this is a complicated question is because the physiology changes during burn shock. And if you don't have ICU management, you just have to know that can happen.
Okay.
So what does that mean out in the field? The reason we have the formulas is because we know that the fluid deficit is whatever that total calculated volume is. Mm-hmm. The best thing for the patient is to give that calculated volume over that extended period of time, and then make adjustments. So what do you use to make your adjustments? Well, if the patient's urine output is really dwindling down, look to see if you might need to do an escharotomy, or maybe you've already done an escharotomy. Or look to see if the patient has an inhalation injury. And remember, if it's greater than 40%, the airway needs to be controlled.
Right.
I'm going to make just a parenthetical comment about airway control, if I may.
Sure.
So this is one of my personal, very strong beliefs, that if a patient needs an airway, then do it and get it in. If you don't think you can intubate a patient because they have a bad burn on their face, then do a cricothyroidotomy. I know the people who are listening to this program can do a cricothyroidotomy. The hardest thing about doing a cricothyroidotomy is the decision to do it. You've been trained, you know, you've got a bad situation, you've got a tube, and you need to get an airway, make it so. Just take care of it. Because for a burn patient, that becomes a big issue if you haven't done it up front. So let's say you have a big burn, 50% burn. You know you got to get an airway one way or the other. If you get it in earlier, it'll be a little less difficult to get the airway secured, oral tracheal intubation. And then if you've got third-degree burns that look like they need escharotomies, then you got to do those. And then you remember 50% burn is going to require a liter an hour over time. And then you're going to follow the urine output. If you don't have pressors, and all you have is fluids and, say, your ability to clean the wounds and do Suvrlon, then be very cognizant of the possibility you might need to do escharotomies. But if you have a normal, healthy person, otherwise, who has this injury and doesn't have any other trauma, you secure their airway, you do the escharotomies that are indicated, and you give them the fluid that we're talking about here, you're not going to do too much. You can't really give too much fluid, and it's hard to give too little fluid if you've already made those other interventions. And then the other issues can be dealt with later. Sometimes people go into renal failure if they have rhabdomyolysis, or sometimes they go into pulmonary edema, or they even get abdominal compartment syndrome. But usually the reason people have gotten that is because they're not just not following the formula, but they're giving more and more fluid because, say, for example, the patient's urine output went down. I recommend you hesitate before you increase fluid like that, because the likelihood when they're oliguric is that they will eventually respond as long as these other interventions aren't required. And if you give them more fluid, you're only going to make it worse.
Right.
So that's I hope that was clear enough.
Yes.
My simple recommendation for how to think about burn shock resuscitation and assessment of burns. I think the key is that it would be nice to have had some experience doing escharotomies. You just have to get through the skin. I like to say an escharotomy is effective when you make the incision, the skin starts to separate.
Right.
Because that gives you an indication of how tight it was. Doesn't have to be perfect. Just like when you do fasciotomies, they don't have to be perfect. They just have to be open enough.
Right.
But you want to make sure that they do open. You don't want to just make an incision on the skin and call it an escharotomy.
Right.
And you want to avoid where the nerves are and the major vessels. And that can be done everywhere. And if you wonder, because some people wonder, they're like, oh, I don't know where to do this, go through the burn.
Right. Yeah. Yep.
Even if it's not what the pictures say, go through the burn.
Okay. Speaking of wound care now, I know that, or we all know that damaged tissue, as long as it's attached to the body, is going to kind of augment the inflammatory response. They're releasing the cytokines that make burn shock worse. When is a patient ready to at least do a gross debridement?
So I think about this a little bit differently than that. I think that what causes burn shock is depth of burn.
Okay.
So I think a third-degree burn causes more burn shock than, say, a deep second-degree burn, and that causes more burn shock than a superficial partial thickness burn. And then clearly the difference between that and a sunburn or even road rash, which is fascinating. So over the thousands upon thousands of patients I've seen now, I do think that depth of burn really matters.
Okay.
And that may get to why people go into burn shock in the first place. We don't really know. But I think that one of the keys that you can do is clean up those wounds. You had mentioned dirt.
Mm-hmm.
So ABCs, airway, breathing, circulation. You want to get that stuff started. If you're talking about a burn that's less than 20%, that's not in burn shock, then it's really about pain management and making sure you can balance that. But get those wounds clean. Okay. If you have in the guidelines, they're pretty clear, and I agree with how you would clean a wound and how you would debride it. Mm-hmm. So a debridement is where you take loose tissue. Mm-hmm. Where it gets trickier is where you do an excision, where you take dead tissue off. I wouldn't recommend that. I think the key is to get the wounds clean, get the dirt off, get the patients dressed in an appropriate antibiotic dressing. In this case, Silverlon, a silver impregnated dressing, that's for the clinical practice guidelines, and then follow those criteria and make sure that the eschorotomies are done appropriately. And generally, patients won't get into infectious complications right away. Right. But how you treat that wound initially will have major impact on what happens. So, for example, you have some sort of an explosion and there's material that's embedded into the wound. Surely you'll get a cellulitis earlier because of that. And you may or may not be able to get that material out, but keeping the area clean while not being too aggressive will be the key.
Right. We don't do prophylactic antibiotics, and I'm pretty confident neither does the burn center prophylactic antibiotics. But in pre-hospital, I don't have the same type of lab capabilities as obviously a major burn center does, as far as identifying the specific agent and being able to identify the absolute best antibiotic. Do you have any recommendations as far as just go with the biggest gun you have right up front, as far as I'm recognizing that there is some kind of infection? Or
well, I can't remember who it was in the Revolutionary War who said, wait till you see the whites of their eyes. Mm-hmm. And the whole point of that was don't use up all your ammunition before it's going to do anything.
Right.
Same thing with antibiotics. If you start administering antibiotics, all you're really doing is circulating an antibiotic, and it's not doing anything, and then it goes out the urine, right, or the GI tract. So the problem is of course the skin being one of the largest organs in the body, mm-hmm, and grossly contaminated, but now open, right, and maybe has dirt on it, is that it will take some time, but it will happen that the patient will get an infection. And so the most important thing to do is to clean the wound, get the patient resuscitated, because if there's ischemia and poor perfusion to the tissue, that will just only aid in the development of cellulitis or infection. And just be on the lookout for the patient, because unless they had a viral infection or some other problem beforehand, we sort of think about burn shock resuscitation over the first 36 to 48 hours. Then there's this window of calm, up to 7 to 10 days actually, okay, even with inhalation injury, where things are pretty calm. Now, you might get burn cellulitis if it's a dirty wound within about 5 days or so, but you don't want to be wasting your antibiotics before, right, there's anything to treat. So I agree completely that you don't want to try to give prophylactic antibiotics, mostly because you're using up a precious resource and you're not treating anything.
Right.
Will you have to treat something? No question about it. Patient has not only exposure, but an impaired immune system. Mm-hmm. And over time, as they're dedicating their energy to heal their wounds, they're going to be immunocompromised, and they will get some kind of an infection, right, most assuredly if they're out in the field.
Okay. Do you have any recommendations as far as antibiotics to pick? Do you just want to go to the broadest spectrum?
Yeah, so it's a good question. I think that the problem is you kind of got to use what you have,
right, and
most of the time these will be gram-positive infections out in the normal field here, mm-hmm, but depending on where this occurs and what part of the world, you might be faced with unusual gram-negatives, mm-hmm, such as Acinetobacter, which occurred in Iraq. But there are other very virulent gram-negatives, and then of course and then anaerobes. Mm-hmm. So I think if you have cellulitis, though, generally I use some sort of cephalosporin and maybe a fluoroquinolone to treat the gram-negatives. I would save the bigger antibiotics, the Zosins, the ones the imipenems, the meropenems, for when you really are struggling. So okay, if you had a first-line set of drugs, I would do that. Again, it goes back to the principle of don't throw everything you have at the patient until you need to.
Okay.
Because you probably will need to.
Oh, yeah. I think so. All right.
May I make one last
Sure thing.
observation about fluids?
Yeah.
So sometimes people ask, why not use normal saline? What's the problem with normal saline?
Acidosis.
Yeah, so it's this hyperchloremic acidosis. So what do you do if you don't have LR?
I mean, I don't know. What do you do?
So that's the reason I brought the point up, is if you have half normal saline, you can add an amp of bicarb.
Okay.
So just look at how many milliequivalents of sodium bicarb you have. Usually it's 55. And if you have half normal saline, then you've got 75 milliequivalents of sodium, 75 milliequivalents of chloride, and then 55 milliequivalents of bicarb, and an additional 55 milliequivalents of sodium. So you're looking at around the LR range, but you actually have a little bit more bicarb.
Okay.
And so instead of giving people 20 liters of normal saline
Right.
and causing them to have a ripper on metabolic acidosis, you could also give them normal saline and then think about giving some amps of bicarb.
Okay.
When I was in Guam and we had a plane crash, that's what we had to do. We had to add amps of bicarb to half normal saline because we didn't have any. We ran out of LR after the plane crash.
The other part of this conversation I'd like to go over is the AMIT program that UNC has for our MPT, our medical proficiency training. Would you talk to me a little bit about how this got started?
Sure. So I appreciate you asking the question, and of course you can comment on it as well. You've been here the most of any of our participants, and I'm sure your audience will be interested in hearing your perspective. But I'm a Navy veteran. I was commissioned for 19 years. I joined in 1986 when I was a first-year medical student. I really felt a sense of obligation because my life had been, for lack of a better term, privileged. And I still felt an enormous sense of commitment, and I thought this was a way to balance it. And I was deferred through the HP, the Health Profession Scholarship Program, to do residency here at UNC. So I was commissioned in 86, and then I finished medical school in 89, and then finished my residency in 96. And then I was a general surgeon deployed to Guam. And in Guam, we had to do all sorts of things. But we had several incidents. One was a plane crash, a 747 airplane crash. We had Super Typhoon Paka, where we lost power. We had earthquakes. We had to do craniotomies as general surgeons. We had to do a lot of the extreme care that I see our medics and special forces people doing in prolonged field care. And what I was amazed by was the capability of our NCOs to provide outstanding care and really incredible judgment. And of course, many of your folks would also understand what it's like when you're dealing with a junior officer who might be a little bit worried, scared perhaps. And I always appreciated that, sort of that calm under fire approach. So when I came back and I finished my fellowship in 99 after a small stint at Lejeune. And then in 2008, we had a chance to go to the schoolhouse. And that's where I met First Sergeant Landis, Todd Landis. And he gave us a tour of what you all do. And Colonel Kingsbury was the dean of the schoolhouse at the time. And I just remember being amazed. And this was around the time of the surge. And having grown up in North Carolina, knowing that this is the first public university in the country, and was founded by William Richardson Davie, who was a Revolutionary War hero, and that JFK got an honorary degree in 1961, the same day he approved the wearing of the Green Beret. And we work here in Memorial Hospital, which is dedicated to those who have served in the armed forces. It was quite clear to me the only reaction that I could have was, how can we help? And at the time, we had gone down with a businessman, Stan Eskridge, and an investigator, Tom Fisher, and then the chief of trauma at the time, Chief Rich, and my brother, who was the chair of emergency medicine, now is the dean at the University of Arizona School of Medicine in Tucson. And the question was, there was really two needs when we asked what could we do. One was get some experience up here, which ended up becoming AMIT. That was named by Todd, by the way. That's why a lot of these things have been determined by the 18 Deltas who started the program, and help people with their professional development, whether that was medical school, nursing school, PA school, and that ultimately resulted in, could we create a PA school here at UNC Chapel Hill? So this was 2008, and General Schrenko, I think he was the two-star, was the head of the training command, met with our dean, Bill Roper, and President Bowles of the UNC system, and there was great enthusiasm. And so I think that on both sides of the aisle, a lot of tape was cut quickly, red tape was cut quickly, and we were able to get AMIT program started. And then in 2012, the School of Allied Health received a grant from Blue Cross Blue Shield. And then there were a number of other instrumental supporters, the Fulghams, physicians here in North Carolina, alumni, and the Keenan Trust, who helped us build this program such that we now have, our first class was actually graduated of 20 students, started in 2015, and 45% of the graduating class were military veterans or somehow associated with the military, which is by far the highest percentage of any PA school in the country. In the meantime, we continue to work with the deans of the schoolhouse. So we had worked with Colonel Lutz and Colonel Kane and Colonel Landers, and each one of the AMIT liaisons is selected by their predecessor. So Todd selected Eric Strand, who's now doing, he finished medical school and is now doing pediatric anesthesia up at Yale, and Carl Holt, who's now a third-year medical student here at UNC Chapel Hill, and then Ron Brady, who's now a first-year medical student here at UNC Chapel Hill, and then most recently we're working with Shane Cronstedt, and it's really been an incredible experience for me, and we try to expand and develop these rotations more and more to get people what they really need. As you know, we have a couple of people up here, including yourself, and maybe you can speak to what it's like to be on the other side of the aisle.
Oh, absolutely. My first AMIT rotation was, I think, about 4 years ago, and that's when I really started realizing the way things were starting to turn as far as the war effort, care in Afghanistan, Iraq, that was starting to wind down, and everybody knows it winds down in one place and it picks up in another place, and usually those places have very little infrastructure. So I was really interested in the prolonged field care type of a skill set, and so I came here to the AMIT program wanting to expand that ability. I had a fair amount of experience in combat doing basic T-TRI-C things. What I didn't have a lot of experience at is taking care of one person for a really long time, and I was able to find that in spades here at the AMIT program, where I could take care of essentially the same patient, or a few patients over a week, 2 weeks, 3 weeks, as long as I really wanted to, and follow them through their entire course. I've been able to get experiences in all of the different ICUs, in surgery, really anywhere I felt I needed to go, and get the education to help bolster my abilities.
Well, when we created AMIT, the idea was to bring operators such as yourself, experienced people who were trained and had been out in the field several times, and perhaps were at the schoolhouse as an instructor or a senior member of a group, and say that the healthcare system, or the UNC hospitals with its base at the Burn Center, is open for you to get some in-depth training that may result in some instruction that you may take back to your students, or maybe some exposure to academics and how the academic healthcare system works and functions and navigates. Maybe it's the good parts as well as maybe the parts that we need to improve. And we've benefited enormously from the information that you've shared with us, the talks that you've given us, the focus on competency-based education, and also the partnerships that have and the friendships that have lasted over a decade. And of course, as the nation's oldest public university, our goal is to have this be in perpetuity, but also for it to continue to evolve. We've had several of the AMIT participants go to DO school, go to medical school, now come to PA school here at UNC. We have other career development goals as well, but it's really driven by the needs of the Army, the needs of the folks who are out there in the field, and how we can help, and then how can we help other institutions that have similar views or maybe are far ahead of us in delivering this. The only difference I would say about UNC Chapel Hill compared to some places is geography. We're about an hour away from the center of the Special Forces universe, as far as I understand. Yeah. And we have one of the largest burn centers in the country, which is a unique, I think, educational experience for people. So that makes it advantageous in that arena. And of course, we're very willing to support all of the people who have served our country so well and so selflessly. But we also are very interested in constantly retooling and doing more with less, just as you have to do with prolonged field care. So that's been the vision of it. And if it's successful, it's because of the people like yourself, Dennis, who participated in it.
What are your future plans, your future goals for this program?
Well, they are as ambitious as they need to be to serve the goals of supporting you and your colleagues, because I am concerned that the world is becoming a more dangerous place. I am concerned that we have a tendency to get caught up in the lesser important deals, and we may have a very big problem happen very quickly, and we need to be ready. And you all will, as always, be at the tip of the spear and help us get through that. We need to be backing you up. So, very fortunately, our Chancellor, Carol Folt, has been a huge proponent of the military programs here at UNC Chapel Hill. We now have UNC Core, which is an online program to help people get the first 2 years of their bachelor's degree at UNC Chapel Hill. We have an increasing number of expanding programs here on our campus, but we're also very fortunate. Margaret Spellings, our president of the UNC system, was the education secretary under George W. Bush. And we have a 17-campus system here at Chapel Hill, and there's strong support for the military. Many of our UNC sister campuses, places like Fayetteville State and Western Carolina, I'm sure you're familiar with, support our military and their educational programs. I'd like to see more coordination of this. I'd like to see our PA program continue to grow. We have 20 students now. I'd love it to be 40, but still with our high percentage of veterans. We have some faculty that will be former military that I've worked with that will be here. I think that will really help. We can continue to expand AMIT into the PA program and maybe the medical school program and maybe some of the nursing programs. And we've so far been unsuccessful, but would like to again pursue research funding, either with prolonged field care or developing devices for the Special Forces or any other collaboration with military medicine. But I think the best way to answer this question, Dennis, is to ensure that this university, this medical school, this burn center, me as an individual, are fulfilling our obligation to those who protect us. And that's our young men and women of this country who are in the military, and in particular in North Carolina, whether they're in the Army, Navy, Marine Corps, Air Force, or any other National Guard, and do whatever we can to serve them. That's our purpose. I know that our citizens of the state, if you ask them, even if they're of limited means and limited education, they will say, take care of our military first. You do that, then we'll take care of you as a university. And we think that that's going to be the best way for us to continue to grow and continue to be successful, is to never forget that.
All right. Well, thank you very much, Dr. Cairns. I really appreciate it.
Well, thank you, Dennis. It's been a pleasure. And thank you to all your colleagues for their service. Really appreciate it.
That's it for today's podcast. Be sure to go to our website, www.prolongfieldcare.org. Find us on Facebook, YouTube, Instagram. Subscribe and stay on the bleeding edge of combat medicine. This is Dennis for the PFC Podcast. Out.